Okay, today we're going to do chest tubes. We're not going to discuss the whys and wherefores of a chest tube because that's pretty much the doctor's domain. He will tell you what he wants and he will pull his chest tubes most likely. But we're going to go over the nurse part and the assisting part. First thing, make sure you have suction. So liner, tubing. And if you need more for suctioning the airway, you need 2 suction canisters, 1 for each. Make sure it works. And it does. So after you check that, then we're going to come over here and we're going to get out our kit, which is going to be right there under B for breathing and the Dry Oasis suction kit. Now right there is your chest tube insertion tray, which you're probably going to get a little bit different at some time in the future, but for right now, just grab that green thing. And right there are the chest tubes. If the doctor hasn't picked his own, ask him what size he wants or show him where they are so he can choose. Then, having that said, this is only going to focus on setting up the chest tube part. Ideally, it's more than just you in here because generally speaking, there's a lot of things going on at the same time. But for your part, you do not need to be sterile for this. So we're going to take our we're going to go over to the suction part of this, I do believe, so we can show this easy. And really there's not much to setting this up, other than the fact that you want it in an area that's not going to get tripped over, not in the way. So here we go. Kit. You're going to open it up, pull out your suction, or your, Then open up the first sterile sheet, and then the second. Like I said, you do not need sterile gloves for this, or any gloves for that matter. Then you're going to get your kit, which is the Atrium Oasis. It's got a little foot here that you can snap down in place so that it doesn't fall over. Then on the back of the unit, there is the water that you need, and it's going to be right back there. If you can see it right there, it actually goes right there, so you just have to pull it out. And it is glued on a little bit, so you might have to pull a little bit. Snap off the plastic top, and it's already pre-measured. It is sterile water. Then right there is where you're going to put it. So I think it's about 30 cc's that goes in there, and as you can see, there's a blue dye in there, and we'll get to that later. So you're going to put, it's going to come right down to that green line right there, which is generally the entire contents. There we go. Now, and let's see. So if you can see right there, you have your water line is even there, and there's a blue dye in there so that you can see it up against the white background. So that is the first step. Number 1, or number 2 rather. These suction things are already set for -20. That's the default setting. There's a little wheel, which is right here, that you can turn. That controls your suction. The wall is yes, no suction. This is how much suction. So, unless the doctor tells you otherwise, you leave it at -20. That being done, next thing you're going to do, we can get this stuff out of our way, because everybody's running around. Doctor wants you to be ready when he's ready, and he's wanting to have it done yesterday. So, you open up your suction tubing, because this is all the part you need for that. And you're going to hook it to the wall. And we're going to put it to continuous suction because you do not want it intermittent. And check out our suction because it's always best to do that. You're not wanting this at super high rates. So let's see, we're going to adjust this down to maybe 100. Now, we'll find out because we're going to hook the blue suction to the suction port, and it says suction. Now, this is what you call an air leak. Now, obviously there's going to be an air leak because it's not hooked to anything. That is a normal finding. Now, there is numbers in here, 1 through 5. You can tell your air leak by how bad the... I'm going to turn this off for a minute. You can tell how bad your air leak is because you'll have bubbles. They'll be gentle bubbles from the 1 through 5 spot. This is a baffle that lets you know it's a positive indicator that you do have suction because it'll come out into this window. So, that being said, this right here is where, now sometimes depending if the patient has like a really strong inspiration, you may end up with water starting to back up in here. So to get that to go down, there is a little valve. Let's see if we can see it. That won't happen normally because I had this apart earlier. But let's see, right there, you'll see a little button. You're going to hit that. If you hit that, it will release the water, release the pressure and keep the water from going up in here. Because what you don't want, you want only the things that's coming out of the lung cavity to fill up this, whether it's serous or whether it's just sanguineous or just frank blood. So you would prefer, because you're going to keep very close attention to what your drainage levels are. Now, that said, this part you keep in the little, there's a little bag that's attached to the back, and in it you're going to find the other end. This is the end that goes in the chest tube. Now this is sterile, and because that chest tube goes in there. Now on this, you leave this alone and you leave it in that little sleeve until the doctor's ready for it. Now once you have everything hooked up and ready to go, then you're waiting on the doctor. So let's say the doctor, he's got that chest tube, he puts it in. Generally speaking, it may or may not be swoosh and spectacular, but what you want to pay attention to right after it gets in. Now, when it gets in, he will have the chest tube, the open part, in his hand. You take, when he says he's ready, you take the tubing and you pull off the guard. I would have gloves on for this, but not necessarily sterile, because you're going to hold it kind of like that, and then he's going to put the sterile end onto this tight. When he is done, then you can take it and make sure it's really tight. But he also has to suture it in, so make sure he's ready for you to manipulate it. But you want it you don't want this coming off accidentally. That could be catastrophic to the patient. So, that is now hooked up, and he's suturing it in place and putting a dressing on it. While he's doing that, you're going to come over here and turn the suction on. Now I'm going to put this little clamp on so we can keep, because when it's in the chest cavity, you're not going to have like a ginormous air leak. So here we go, regulator on. Now this is like totally off. So you would expect there to be a minor leak if it's been in for a while and it's been healing up. You would expect to have at least, you wouldn't expect it to be boiling like it was boiling, but, and that's kind of high. Let's see if I can do this. But you might expect to see something along the lines of that. So gentle, so it's hard to do this when you're squeezing the tubing. But that would be a 1, if you can see that, that would be a 1. And if it was like that, it would be a 2. And you're never going to see that without being a massive problem. So, and if you notice, that baffle is all the way in that window. There's no, like, there's an arrow there. The baffle should reach out to the window, because if it doesn't, you may consider that your suction's not high enough. Again, you don't want to suction the lung out of the cavity. 100 is a good rule of thumb. And you may need to go down a little bit, but you don't, once you get your wall suction, don't worry about changing it, because you're going to change the suction by that little wheel. And occasionally they have 10, rarely do they have 40, so it's going to be pretty dang rare that you're going to change any of that. But there's 10, and you can see that baffle move as I switch this, because more suction is going into that baffle. And you can see the baffle's kind of vibrating at the moment, because if we were actually using that as a level, we would be turning the suction down on the wall a little bit. Now, we're going to turn this off for a bit so we don't boil away. First thing, after you get that part hooked up, you're going to want to note what's your air leak at. But before your air leak, that's not as important as what is your initial drainage and what does it look like, because you need to document that. And you need to put like a little, usually we put a little pen mark or a little Sharpie mark and put the time that of the drainage. Because you want to let the doctor know of any drainage that's over 200 an hour. They usually will tell you their parameters. They're standing there when they put it in. So if you have like 1,000 out right away, that's a problem. But generally speaking, you shouldn't be draining more than 200 an hour, especially for more than 2 hours in a row. So mark the drainage, and anytime you have a significantly increased output and or it's been kind of going serosanguinous, now it's just red blood, that's a problem. Call the doctor. And assess your patient, of course. Now, on the back of this, if you look, there is a little rubber stopper, and that's in case you have to take out some water because of what reason I don't know. That's usually the case when we're putting it in by measuring it. That pre-measured little syringe that sticks right there pretty much is foolproof, pretty much. Now, in the event that you've had this in for a while and or you have 2,000 out and you need to put another one on, you pull another atrium, you open it up, don't have to worry about being sterile. Now this time, this part's in the patient. Before you disconnect it to the patient, you're going to want to clamp right here. Now, you do never, ever, ever leave these things clamped. So you want to, think about this. Clamp. Then, you're going to disconnect it right here. Now, this part's hooked to the patient. You get your new one of these that you've taken out the other one so that it looks just like that. You throw this away on the new one. Then you plug, this one's in the patient, plug that right in there, and immediately let this go. Now, you should see nothing other than you now have a new canister. You shouldn't have any frank blood output. There shouldn't be any change in your drainage. You would expect to see none of that. Of course, after the chest tube is in, you listen to the lungs, evaluate for breathing, keep a close eye on crepitus. So if it feels like Rice Krispies under their skin, investigate. That's not terribly abnormal with a pneumothorax necessarily, but it shouldn't all of a sudden appear if it's not been there since the beginning. Also, you want to tape your connectors. So where the chest tube is connected into this, you push it on there real tight, and then take, usually we use pink tape. We don't have that here, but we'll look about getting that, because you don't want paper tape. You don't want the that clear, easily rippable tape. Silk tape is not the best, so we're going to try to find a better solution. But you would tape the connector from the chest tube clean across this down to here, and then I do it again so that and you would make it narrowish because you want it to you want it to keep these two pieces from being pulled apart. Now, you can still pull apart if you try really hard, but what you're trying to avoid is accidentally having it dislodge while the patient's rolling over, while you're pushing the patient down the hallway. Same thing with chest tubes, same thing with Foley goes with chest tube. You want these things, now they can sit on the floor, but you want them below the level of the chest. If you have to transport the patient, below the level of the chest. You do not have to put them on, keep them on suction, because this is what's maintaining their negative pressure in the pleural cavity. The suction just helps inflate the lung a little bit better. And depending on if it's like a 50% pneumo, 80%, at the higher percentages, you do need a little bit of suction to keep that negative pressure area, especially if you have a big tear in the lung. And you would expect to see, you would document every shift, your character and quantity of your drainage. You would at the end of the shift put a mark with the time on there, document how much output you had. document what your water seal or your water leak is from 1 to 5. You would, SATs, respiratory rate, lung sounds. And if the patient feels like they're in distress. Now, in the event that you end up with a patient who all of a sudden gets frantic, they're check immediately for tension pneumothorax. That shouldn't be a problem, but in the event that something happened with the chest tube, like it came apart, look at their trachea. Is it midline? Listen to their breath sounds. If you hear no breath sounds, they're panicking, SATs are falling. Troubleshoot your chest tube and call the doctor simultaneously, and kind of go from there. If this is full, change it out immediately. But don't change the suction and all that unless you talk to the doctor. I have one nurse calling the doctor at the same time I had another nurse checking to see whether or not it's intact. Because sometimes, even though they're sutured into the chest wall, a patient will get rambunctious or a knot will come loose and the chest tube will actually be out of the chest. And out of the chest, it doesn't have to be all the way out. As long as one of those eyelets is out, it's not going to do its job. And you need to take the dressing down in the event you have a problem with the patient to make sure you don't have an eyelet sticking out. Generally speaking, you wrap around and you use Zero Silk with a Keith needle to suture these in. You put Vaseline gauze around right where the chest tube goes into the chest. That kind of helps seals it off. And then you put an ABD pad or some other dressing. Be careful that you don't overdo a lot of tape, because you don't want to rip tape on and off, because it'll give them basically a good burn, because it'll yank their skin off, and you don't want to do that. So that's pretty much it. That goes through the things to watch for, and you can definitely need a chest x-ray so you can see where your chest tube is, if your lung looks better, all that kind of stuff. And that will be all there is to that.